again, I'm going to welcome all the participants, okay? And definitely our speaker, very eminent speaker, he already becoming so much familiar, and not only that, even the last day, 12th September, he came and he had made a very beautiful, friendly atmosphere among all the participants, all the students and all. And that's why he became so much familiar with our all students and all other participants too. So there is no record to again making any brief introduction and all. So we are knowing today our speaker is Dr. Prasenjit Chatterjee, sir, and he is now attached. He's a radiation oncologist, and he's now attached with Tamri and Apollo Gleneagles and Woodland Nursing Home too. And today his topic we are knowing that is the lung cancer. So warm-heartedly I'm requesting sir to start his topic. Okay sir, please start sir.
Yeah. Good evening, everybody. Am I audible?
Yes, sir. Audible, sir. Audible,
okay. Sir. Yeah. Welcome again. So it is September is something very precious that we are meeting in more than one occasion. The last time we had a brief discussion about COVID and cancer. So this time we will have a discussion a bit about lung cancer. You know, lung cancer is one of the commonest cancer in India, and it needs an emphasis because of its huge incidence of the disease, as well as the being a fatal disease, because its mortality is also very high. So it's very important that we understand a bit about epidemiology, the disease burden, and how it starts. So I'll try to make a very brief presentation, and as usual you can make your comments and queries in your chat box, so we can answer them while the presentation is over. And let me see if I can start it once again. So I'll start the presentation. I'll be speaking about lung cancer, as I discussed. Now, coming November is the awareness month of lung cancer. So we are heading towards November, and we are in the middle of this unprecedented crisis of COVID. With that, I'll just try to give you a bit about introduction, how lung cancer is so important. So I'll be covering a topic about classification of lung cancer, the risk factors enabling this disease, some important signs and symptoms, diagnostic information of lung cancer, and of course staging specific. Most of you are also seeing a lot of cancers in different stage. We know lung cancer is usually a advanced cancer to begin with. We'll talk a bit about treatment and side effects also, and finally if there is some preventive health strategies that needs to be implemented. So as you know, the slogan for World Cancer Day this year, 2020, is Together We Can. So with that, lung cancer was the most important theme for this year's World Cancer Day presentation. So I'll try to be as much as possible short and brief, because we have 45 minutes time. I'll try to cover up in that period, because I have another back-to-back presentation today. In fact, I have preponed my presentation for the same reasons. Now, what is the epidemiology? It constitutes almost 7% of all cancers, new cancers I'm talking about. And of the death which happens in both the sexes, it is almost 10% of all cases. And it is the commonest cancer and its commonest cause of mortality in men as well. Now, so far as survival index of this cancer is concerned, we say 5-year survival is approximately 15 to 20%. And unfortunately, as most of you are aware, screening. What is screening? Screening is examination of the mass population to benefit a bit of the patient who are at risk group. Now, screening is not a successful proposition according to the US task force huge study which has been done. So, because doing a chest X-ray is not that we pick up the disease at a very early stage, because chest X-ray usually defines a tumor more than 2 centimeter in size, and tumors less than 2 centimeter is usually picked up in a CT scan. But unfortunately, we cannot do a routine CT scan as a screening tool for most of the patients. So screening at the moment is not recommended in the Western countries also, but we do screening only for high risk group. I mean, patient who has a family history or patient who has long smoking history or maybe some other symptoms like hemoptysis, there's blood in the sputum with other predisposing causes, maybe working in an asbestos factory. There are all those risk groups which needs to be stratified and equally given importance. Now, how air pollution has an important role to play. Now, outdoor air pollution category 1 evidence there is link between cancer. This is according to International Agency of Report in Cancer, which is located in Lyon, France, and they have reported that air pollution index certainly play a very important role so far as cancer is concerned. Now, being that is a fact, we have to be very careful because vehicle pollution is the most important concern, and you know one of our cities, Delhi, the capital city, there was a lot of hue and cry last year about this issue and becoming a health problem. So there were rules trying to be implemented like odd cars and even cars running on alternate days. Like Monday, the numbers ending with odd numbers, they will be able to fly or maybe run on the road. Similarly, on the next day, Tuesday, only the even car numbers, the last digit being even. But unfortunately, that was successful initially to begin with, but it could not be executed because of our constitutional guidelines. So there are some important issues which needs to be addressed to cut down on air pollution index, which not only leads to lung cancer, but it leads to not many other diseases as well. Now, EPA estimates that vehicle pollution accounts for almost half of the cancers. Besides the smoking habit and other habits, risk factor stratification. Now, vehicle emission is very important cause, so we have to be taking into consideration how this factor can be cut off by controlling the vehicle pollution. Sometimes there is technical hitch, like at the moment my slide is not going down. Yes, now I am done. So, what are the sources of emission of air pollution? It can be industrial air pollution, that can be transportation, agriculture, as well as commercial products. Now, we know that industrial exposure of this pollution is the most important cause which has a bearing so far as a disease called lung cancer is concerned. Now, this is how a smoking causes a fatal lung cancer, a schematic representation how the lung looks in the pictorial representation in a smoker vis-a-vis in a non-smoker, as you can see in this picture. A bit about fact sheets, some important data according to the incidence and cause of tobacco being the reason for lung cancer. Average age of initiation of tobacco is less than 17 years in our country, and a quarter of the female population starts tobacco before the age of 15. I don't know how much of you are aware of that. Did you have read across any good studies? There are a lot of studies in the Google also regarding the females starting with smoking. There is an increasing surge of smoking in the women population, and current tobacco users are male around 50%, and women it is on the rising surge. It is to the tune of 20%. This is the global adult tobacco survey data 2009 and 10, and over the last 10 years this has doubled. So I just wanted to share what we were at the point a decade back vis-a-vis as of today. Now, men who smoke, they are 23 times more likely to develop lung cancer than those who don't. And vis-a-vis so far as women, they are at the risk of 13 times more. That is 10 times, not even more than 10 times, it is 13 times. So try to understand the implication and extrapolation of data when you see smoker versus non-smoker so far as incidence of this type of cancer is concerned. So I would always like to share you the data. If anybody interested at a particular individual level, you can certainly mail me or you can WhatsApp me also. My number is there in the last slide, or you can share with the principal or Dr. Priyanka, they all know. So there are so many important data we will be discussing, and a part of it you may miss because of lack of concentration, or maybe all of you are into so many activities in this pandemic times that you may miss the data. But I'll be more than happy to share these data with you as and when you feel that you need that one. So you can mail me, and of course you can WhatsApp me also. All are welcome. So one more thing, don't know why this is getting stuck. I'm sorry for the delay, but yeah, the probability of lung cancer. We all know smoking is dangerous. The increase risk of lung cancer is between 5 to 10 times, and it is 24% smokers. This is all across the board, irrespective of sex, who can expect to develop lung cancer during their lifetime. So, of course, young friends of mine and colleagues, one who are really smoker or who are just casual smokers as of today, I have a word of warning to you, a word of caution that this is certainly linked to you a more increased pollution and increased risk of lung cancer over a period of time. You people are too very young at the moment, don't understand the seriousness of this disease, but it has an implication on long term. So I would always advise, being health caregivers, you should have an awareness of how this is important for all of us, and we should take care about these issues. So these are the small schematic presentation again, different carcinogens which are available in the atmosphere, and they are individual or maybe in a conglomerated form cause lung cancer. There are more than 4,000 such chemicals, and out of these 50 of them are more carcinogenic and may be reason for only exclusively lung cancer, besides other cancers like urinary bladder cancer, like breast cancer. These are the other two very important cancers where smoking has an important predisposition. So this is a very important slide I would share or make you take a snapshot of this, or I would share you if you ask me for this slide, because this is a very important slide which I believe you should also share or make a presentation when you are presenting in your own forum in different clubs or associations which are related with healthcare workers or maybe the community at large. Now, what's in the tobacco smoke? How this is dangerous? There are different particulates which are available, out of which nicotine is the most important carcinogen. Apart from that, carbon monoxide, nitrosamines, there are other so many carcinogens present. So these are the chemical compounds which are in active form and has a bearing so far as dysplasia of the lung tissue is concerned. And dysplasia, as you know, is the beginning of cancer. We say dysplasia, metaplasia, and then it is cancer. So carcinogenesis happens in this precarcinogenic stage, which is called dysplasia and metaplasia, which ultimately leads to carcinoma in situ. Now, how this tobacco epidemic happened in our country? I have got some raw data which has been shared by the tobacco lobby of the government of India, and these are very, very important. 5 million deaths due to tobacco use, out of which 1.4 million resulted from cancer. 8,50,000 deaths, that is almost a million, is due to lung cancer. So tobacco use has a very huge bearing so far as lung cancer is concerned. Now it is projected that 20th century there will be 100 million deaths, and there will be almost a billion deaths in the 21st century. This is a projection. This is a worldwide global stratification or data projection which is going to happen in the developing countries. So mind you friends, today we have got a very important topic we are discussing, just to alert you, again just to make you understand that it's very a casual thing, and it has been seen that the increasing in smoking in men is not so high vis-a-vis the women population. So there has been an increasing surge, and that is what we are copying from the Western world. This happened a decade back in the Western countries like North America and Western Europe, and that is what we are following today in Asia and India. So beware of this. If an ounce of prevention is better than a pound of cure. A general overview, how does a lung look like? I think most of you knows you have got a anatomy as a subject in your syllabus. So you know we have got two lobes in the left lung, the upper and the lower, and there are three lobes in the right lung as shown in the presentation pictorial pic. And there are two main types of lung cancer. How many types? We normally say type is very important. Why we do a biopsy or a FNAC test? We understand the type of lung cancer. There are various types, as you understand. Essentially, we divide lung cancer into two types, that is small cell lung cancer and non-small cell. Now, small cell comprises a little small group. It is around quarter of the all lung cancer, 20 to 25. Majority of them are non-small cell lung cancer. So we call it NSCLC. NSCLC. That is the short form of non-small cell lung cancer, which has a very high incidence in India as well as in other developing countries also. This is a chest X-ray film. How does a schematic PA view looks in a right upper middle lobe cancer? This is shown by earmarked red color over here. This is how it looks in a chest X-ray when the tumor is more than 2 centimeter. This is a typical small cell lung cancer. Now, of the non-small cell lung cancer, we call it NSCLC as we discussed, there are again three subtypes. Yes, it is very important for us to understand the subtypes. Why we are saying that? Because the outcome, the prognosis, even the immunohistochemistry expressions, they are different for different subtypes of non-small cell lung cancer. Essentially, we have three types: squamous cell adenocarcinoma and large cell carcinoma, as you can see in the screen. Now, a bit about information: squamous cell carcinoma. It is moderate to poor differentiation. It makes majority 30 to 40% of all lung cancers. More common in males. Most commonly occur in the central large bronchi. You know, bronchus is the unit of lung, pulmonary parenchyma, and this leads into alveoli. And alveoli is the smallest unit of the lung. Now, it is the bronchus that is the next small unit from where a tumor usually starts growing. So, bronchus is the most important. That is why we always advise a bronchoscopy also to be done. It's what is a bronchoscopy? It is putting a camera through your mouth cavity under general anesthesia or maybe local anesthesia, and you see the lung from inside view. Because in a CT scan or a chest X-ray, you see the peripheral and the inside view, but the inner view can be seen. That's a bird's eye view, which can be seen through the bronchoscope. So, because the bronchus is the unit, smaller unit of the lung, so it is essentially the bronchus where the lung cancer starts or originates. It can spread to the liver, the adrenal gland, and the lymph nodes also. Definitely, squamous cell carcinoma is associated with smoking. So, this is the cancer which is more common amongst previous smokers or current smokers also. Essentially, they are not usually visualized in an X-ray because initially to begin with, they are small, less than 2 centimeter, but it is visible on an X-ray when it is more than 2 centimeter. Now, I have put a small representative picture over here. This is called a pan-coast tumor. Many of you have read, you see patients. These are the patients who present with an oncological emergency. Now, why we call it an oncological emergency? Because these are the patients who have a sudden respiratory distress. We call it grade 3 dyspnea. Okay, they have an exertion even sitting position. The saturation gets down to climbs down to 50 to 60%, even in sitting position. So these patients are the patients who have the right-sided upper lung tumor, as you can see in this, and they usually have the first rib of the right upper lung infiltrated by the tumor, for which there is an excruciating pain also along with dyspnea. So these are the two classical features of pan-coast tumor: excruciating right upper chest pain along with respiratory distress. Another common cancer, which is second common following the squamous cell carcinoma. This is a very important subgroup. I want to illustrate a bit on this adenocarcinoma. You must be acquainted with this term. Some of you may not. Young postgraduates, for your learning, I would like to just emphasize on this subgroup. Lot of research has been done on adenocarcinoma subgroup of lung cancer of late, because we have been able, the scientists have been able to identify expression of different mutants in this subgroup of lung cancer. This is again called adenocarcinoma. What type of subgroup where mutants which are expressed over here? They are usually the EGFR, epidermal growth factor receptor. I repeat, EGFR. This is the very important and the buzzword amongst the researchers in cancer worldwide. We do a lot of research in EGFR to try to find out which cancers have EGFR expressions, because those cancers which have expression of this EGFR receptors, they usually do respond to different types of targeted therapy. You can target this type of cancers. What are targeted therapies? The drugs which only targets the tumor and spares the normal tissues all around. So this is again targeted therapy is important subgroup called adenocarcinoma. Usually begins from the gland. They are usually peripheral in lesion. They are not central, unlike squamous. They are central. Adenocarcinoma is usually peripheral. If you see the picture over here, they more commonly occur in women population, amongst never smoker, and for you friends, this is very important. Asian population was seen to have more adenocarcinoma compared to American and the European groups where the adenocarcinoma is also common. Now, large cell carcinoma is another subgroup, which also is an important entity, though the incidence of this cancer is not very common. It usually grows from the outer part of the lung, and here this cancers usually spread or metastasize very slowly. Usually kidney and the liver are the common sites where it usually spreads, but large cell carcinomas to begin with are localized cancer. That is, they remain restricted to the lung parenchyma during diagnosis. So this is a recap how it looks: a small cell and a non-small cell. Squamous, adeno, you say. Small cell is how it looks. It usually involves the entire lobe of a lung. Squamous involves the upper lobe. It looks big, but this is usually not so big. Adeno is usually a peripheral glandular part, and this large cell is small with a perihiral lymphadenopathy. I hope you are understanding a bit of my discussion. I'll cover a bit about risk stratifications. We all know there are important risk stratifications because we are going through this COVID pandemic. We are all discussing day in and day out about the risk stratifications. Here again in lung cancer, risk stratification plays a very, very important role. So normally they are the heavy metals, the pollution, cigarette smoking, the vehicles. These are the common, and of course industrial exposure, what we discussed before. Now, what are the signs and symptoms of lung cancer? The cardinal sign is respiratory distress. We call it dyspnea, as most of you know. Now, most of what the symptom which the patient presents to a doctor or in a OPD is depending upon which side it is already metastasized, or maybe in the primary side. Because when the tumor is in the primary lung, maybe left or right, usually they are not very much symptomatic. And there is accumulation of fluid in the lung, which we call effusion, pleural effusion. I think you have heard about that term. It is collection of fluid in the lung cavity, pleural cavity. Then the patient more commonly presents with respiratory distress, and they report to the physician or a pulmonologist. So location of the tumor is the most important cause of the symptom. If it is local, then maybe cough, blood in the cough, which is called hemoptysis, or maybe respiratory distress, or if it has already spread to the bones like the vertebra or the liver, or maybe very rarely to the brain, it has the local symptoms like backache, if there is a spine meds, if there is a liver metabolism, liver spread, then anorexia, that is loss of appetite, is the most important. And patient's family members come and say that he has lost 5 to 10 kg of weight in last 3 months. So that is the commonest symptom sometimes the patient other family members say or emphasize in your office or in your chamber. So you have to look out for cancer besides tuberculosis, which is also a common disease in our country. Now, what are the signs and symptoms? Normally, we should say depends upon the whether it is localized, that is involving the lung, or generalized, that is already spread out to somewhere else. These are the common signs and symptoms. We discussed it a bit before. This is a breathing problem. The, the sputum, the collection is called phlegm. Normally, the expectoration is thick and mucoid in a lung cancer patient or a patient with secondary respiratory tract infection. Usually, lung cancer patients have a secondary lung infection, so they present with a mucoid expectoration. That is a yellowish green colored sputum, which is thick in consistency. Hoarseness of voice. Another rare but very occasional picture is there is a change of voice. There is a potato speech, we call it. You cannot speak out properly with a normal tonation. Weight loss, we discussed. Chest pain, I told you, especially Pankos tumor. Horner syndrome. I would like to hear from one of the participants. You should write down in the chat box what is a Horner syndrome, because this is included in your syllabus. I will not get into the details. Everything will not be spelled out by me, but I want to hear also how much concentration and attention you are keeping. Okay, so pleural effusion, we discussed collection of fluid in the lung cavity as written over here, and superior vena cava syndrome. We call it SVC. SVC is also again an oncological emergency. The patient usually presents with pain and sudden respiratory distress with swelling of the face, and the veins are very prominent. If you open up the shirt, you'll see the chest veins are very prominent, which is called superior vena cava syndrome. Now, mind you, friends and colleagues, this is also an oncological emergency. What do you mean by oncological emergency? These patients need immediate intervention, and there are only few select group of cancers where you can offer the treatment, maybe radiotherapy or chemotherapy, without the biopsy report. Now, mind you, friends, according to legal ethics as of today, it is very important that you cannot treat a cancer patient unless you have a histopathological biopsy report, confirmed report of cancer, because that leads to medical legal issues. But only in few oncological emergencies like superior vena cava syndrome, as mentioned, you can start radiotherapy or chemotherapy without the biopsy. But there is a caveat, very important caveat in today's world, where we have got the commission and so many bodies, regulatory bodies, who is just chasing after your mistakes, trying to find out your fault and putting you to the court, and you are subject to a lot of, distress and harassments. So you need to take a consent from the patient and the family. If there is not a biopsy report that this is an oncological emergency and you need the treatment, and you give the consent in writing, which you understand in your own language, you understand with a given date. This is a very important talking about ethics and the informed consent. Now, I think we'll have a discussion some other day, because that's a very important medical legal terminology that needs special attention in today's world, where everybody is into consumer protection and lot of issues against professionals like us, healthcare, and lot of cases are going on both in India and abroad. So we have to be more careful and intuitive about how to avoid a medical legal hassle. A bone pain,
Sir,
these are also.
excuse me,
Tell
sir.
me.
Yes, sir.
Ah,
Actually, within 2 minutes, our this session would be finished here, because 40 minutes is going to be finished. So afterwards,
okay.
all the students and all the participants kindly join the same program with the same link. And sir also, just afterwards, whenever it will be finished or disconnected, again you just join with the same link. Okay, sir.
So we'll have just 10 more minutes of presentation, and today I'll be short because I have another presentation. But you can put your questions in the chat box. We can discuss in the second link when you're sending, Dr. Priyanka.
Okay, sir.
So bone pain, headache, these are depending upon which side. Bone pain is if it is in the spinal column. Headache is when you have brain metastasis. Headache is a very common. Abdominal pain is when liver is damaged or involved. So these are the common early and late signs and symptoms which we have already discussed a bit about it. I think 1.5 minutes. What about the diagnostic test? I will not get into elaborate discussion, but normally a chest X-ray, a CT scan, more importantly a PET CT scan. This is a very important diagnostic test in lung cancer. We'll discuss this a bit details. MRI also is very important, especially in brain. Sometimes if there is a brain metastasis, small lesion less than 2 centimeter is not always picked up in a CT scan. You need to do an MRI of the brain because they are more sensitive because of soft tissue delineation better. Sputum cytology, fiber optic bronchoscopy, we discussed that, and transthoracic fine needle aspiration or FNAC. So these are the common things which we do about it. I'll say a bit about PET CT scan. This is a newer imaging modality. I think few of you are well versed with that. This is some special test where we give a guy 25 mg dye. It's deoxyglucose. That's a glucose dye. And where there is a cancer cell, maybe in the lung or the liver or bone, it is usually shown in form of a yellow color. So that is very important. This PET CT scan helps in our diagnosis, how much extent and stage of disease, as well as how much response after the treatment. You do a repeat PET scan even after a treatment. So that is about how we do the investigations and tests in a lung cancer. In the diagnostic evaluation, we discussed about imaging and the fiber optic bronchoscopy. Some laboratory tests are also very important, like the blood counts, the blood chemistry. Now, I would just like to emphasize a bit about biopsy. Now, a bit back, I talked about FNAC test, where we put a needle and do a cytology test. Now, as of today, FNAC in lung cancer is an obsolete test. This is for you friends who are young postgraduates or in the fraternity new. You should understand that FNAC is not the test for confirmation of lung cancer. You need to do a biopsy. This is very important because in FNAC you take a juice out of the tumor tissue and then see in the microscope by a pathologist. But today the things have changed. It is important to get a tissue chunk to confirm the diagnosis because, as I was discussing, firstly you have to know the type of cancer and secondly you have to know the subtype of cancer. So to understand type and subtype, and finally we discussed about the receptor also, mutation things, which is called immunohistochemistry. That's the last line in the given slide you can see in the screen. This cannot be done in a FNAC test. So you have to take a tissue for which you need to do a biopsy. So that's why it's important that you advise a biopsy and not a FNAC. That is something new and we have been discussing with our physicians and other doctors in the platform. And I think it is very important for you to understand why we do that. This is a classical bronchoscope where you put it's a tubal thing where local anesthesia is given and the patient is being put with this bronchoscope and there is a camera inside. You can see the units of the lung, the bronchioles, the bronchus, as well as the alveoli. Now, mediastinoscopy and VATS, these are something very new form of endoscopy. And essentially, we are doing this mediastinoscopy and video-assisted thoracoscopy also to see from the lung more elaborately than a bronchoscope. So these are newer tests. Now we do this for staging because sometimes the lymph nodes, these are the lymph node different station. We have 1 to 14 station of lymph nodes present all along the this bronchi present in each lung lobes, and they are being called level 1, level 2, level 3 depending where it is perihilar, transbronchus, or where the location of the lymph node is. So that lymph node involvement can be better seen through this newer investigation called mediastinoscopy and video-assisted thoracoscopy. These are usually done by the cardiothoracic surgeons. Now this is a bronchoscopic representation, as you can see over here. Mediastinoscopy is we give an incision that's done by a surgeon under general anesthesia. We discuss to see the lymph nodes, and this is a classical big procedure called VATS. This is a short form of video assisted thoracoscopic surgery. So this is also very important for you to understand why we do thoracoscopy. Now before I complete, I thought I'll share this also with you. PET scan, I told you a time back little. This is very important diagnostic tool to understand the stage of the disease, as well as to understand a prognosis where there is a response, how much is the response after the treatment, even on a follow-up also. So this is a machine which looks, PET-CT machine looks similar to the CT scan machine down below. Most of you have seen a CT scan, and some of you who have not seen a PET scan, I thought I'll keep this picture to get you more acquainted with it. A bit about cancer staging. This is very important. You know, early stage has a curable potential. So it is very important we understand whether it is a curable or whether it is advanced where you can control the cancer. Depends upon the stage. We do a TNM staging, tumor, node involvement, which I showed to you, and metastasis. Based on that, we have stage 1, stage 2, stage 3, and stage 4. Now, this is how it looks. For early stage cancer, surgery is the treatment of choice. If you concentrate your eyes over here, 1, 2, and 3A is usually early stage cancer, where surgery, chemotherapy, or radiotherapy is the treatment. Now, in locally advanced, stage 3B, now early, locally advanced, and finally advanced is stage 4. So these are the 3 subtypes based on the treatment options for a patient of lung cancer, which is called non-small cell subgroup, which is majority, 80% of lung cancers, as we discussed. Now, based on the stage, surgery, chemo, and radiotherapy are the different options. I will not get into the details, but it is important that this type of meeting, what we are having is trying to bridge a gap. We already discussed that last time. We need to grow closer amongst the healthcare fraternities, healthcare givers. So I am trying to get you myself acquainted a bit about terminologies, what we use, and the language, what you should also understand, so that we understand each other's language and we follow the same patterns. Suppose the patient is in your locality, or you are the physician of this patient, and I am the treating oncologist. But we should speak a common word. So that is where a common platform is important, and that is why we are over here today for the discussion. The essential treatment options include surgery, chemotherapy, radiotherapy, targeted therapy, and immunotherapy. Of this, surgery, chemotherapy, and radiotherapy are some things which have been used for last 5 decades. There are a lot of innovations done in surgery, chemotherapy, and radiotherapy. But targeted therapy and immunotherapy are essentially more recent, more modern type of treatment which is being offered to the patients. Now, there are different types of surgeries. We will not get into the details because this is just not in our interest of discussion today. The medical management includes radiotherapy, chemotherapy only. This is a classical linear accelerator machine. I thought I'll put it to you, where radiotherapy is delivered through this type of machines, and patient lies down in a couch. For somebody who is not acquainted what is radiotherapy, because it's a very technical subject, and I am an oncologist, I do practice radiotherapy. So here it's like a CT scan, only patient lies down in a couch, and then it's very important he or she is immobilized, and different type of laser markings are done so that patient is reproduced in a similar fashion every day, because radiotherapy is usually given for 5 to 6 weeks, that is 25 to 30 sittings comprising of 1.5 months treatment duration. So these are the machine gantry. This is called a gantry. This rotates actually 360-degree all around. I don't have a 3D view over here, but I can show it to you that this is how it rotates and then delivers the treatment. I thought this is very important. SBRT or stereotactic body radiotherapy. Now this is a very important. I borrowed this slide from my friend Dr. Ayush. He is my junior colleague, my PGT. In fact, he is doing my post graduation under my care. So this is a modern form of radiotherapy called SBRT or stereotactic body radiotherapy. I just discussed a minute back with you that radiotherapy is usually 1.5 months or 6 weeks treatment. Now last 2 to 4 years, lot of research has been done to shorten the duration of treatment. Instead of 6 to 8 weeks, if we can do it in 2 weeks, yes, my friends, 2 weeks, you can do it in 3 to 5 sittings, where you complete the treatment in less than 2 weeks. That is very important for the resource, because our resource is always limited in a country like India. Number two, there are a lot of patients because we are having a population of 1.3 billion plus. Resource constraints and patient explosion are the reasons for us. Even revenue saving is also very important. Suppose you compress the treatment in 1 week or 2 weeks instead of 6 weeks, so definitely the revenue economics also is better for the patient who is paying for this treatment. So these are the very important developments which has happened in last 2 to 3 years in India. And we are offering this SBRT treatment not only for lung cancer, but this is also done for prostate cancer, uterus cancer, for any other cancers. Lot of research, but not approved for all cancers. But 3-4 cancers it has been approved and been in use. This is actually how you see a schematic scan of a patient undergoing radiotherapy in SBRT form. Now, motion movement is very problem. Patient moves with respiration. So this motion management is a very important component of SBRT. We have a very dedicated state-of-the-art machine facility in the hospital where motion management is being taken care so that the motion movement is minimum and we deliver an exact precision form of radiotherapy, which is very important prerequisite for SBRT. I'll finish my last part of the presentation by immunotherapy. This is one more very important development. In fact, there are landmark trials coming in last 2 years about immunotherapy. This is the most important development in oncology in last 1 decade. Lot of drugs are pouring into the market in treatment of different types of cancers, which includes lymphoid cancers as well as solid tumors also. So immunotherapy will be the answer in next decade so far as cancer management is concerned. There are different methods how which immunotherapy works. We are being using it off late in stage 4 disease of different cancer, but very recently in next 2 years will be having lot of data evidence to use it in early stage cancer. Since early stage cancers are curable, at the moment we are using immunotherapy in advanced stage cancer. But I think in 2 years, 3 years, we'll have lot of data pouring in for early stage so far as immunotherapy is concerned. Prognostic factors depends upon the age of the cancer, the type of the cancer, the grade of the cancer, the location of the tumor, how much it has spread, and of course, the performance status of the patient. This is also very important. Now, any cancer for that matter, any patient who needs to be treated, offered an antibiotic therapy or maybe a surgical procedure, maybe a minor or a major, the performance status is the key criteria for assessing the amenability or feasibility of the treatment. I think you all use different performance status. We also use the performance status for assessing the patient's treatment specification. I think we all know a bit about prevention. Chemo prevention is the most important. Tobacco smoke, I'll say within inverted comma, most important cause for prevention of lung cancer. Other chemo preventions include carotenoids, retinoids, which you are also an important member and play a pivotal role in service to this type of cancers, because you play a big role and so far as dietary supplements for cancer prevention. So there are primary and secondary preventions. It's primary prevention I discussed. Secondary includes where you diagnose the high risk cases, where you do the imaging studies. And tertiary is when a patient is treated with cancer, how far he remains good, a survivor of cancer or cured with cancer. So there are different government initiative. We need more initiative. I don't know whether you have seen a hybrid car already into Kolkata. There is a green number plate being used. I think almost 100 cars are being registration is done, and they are on the road. They are being used. They will be the future answer in a country where there is a lot of population, lot of cars with small roads. So hybrid cars is one way where emission of pollutions can be reduced in a big way. Another is counseling. Another important aspect we usually forget. Psychological aspect of a cancer patient is very important, needs to be given special weightage, because coping up with the diagnosis is itself a shock. So initially there is a denial, there is a shock, and then there is a stage of acceptance. So always think about referring a patient to a psychologist or a counselor, or one should be having enough time to discuss with the patient and the family members about counseling aspect also. Now this is very important. COVID and cancer, we have prioritized in today's pandemic which patient needs to be treated and which patients can be deferred or delayed the treatment. These are the prioritized according to the this Royal Marsden protocol. They are the UK-based hospital, cancer hospital, Royal Marsden Hospital. They have given a high priority, intermediate priority, and low priority. In fact, we in India, in Tata Memorial Hospital, my parent hospital, my alumni hospital also follows this protocol. And this is a good way where we can prioritize in this COVID pandemic. Thank you for your patient hearing. Thanks once again.
Thank you so much, sir, for very informative presentation. Now, one question already came to our chat box. Kindly see, just you go through this chat box. There it has been told, it has been asked that what is CECT test?
CECT is contrast enhanced CT scan. Normally in CA lung, we either advise a CECT. Unless you write CECT, the radiologist will not use a contrast, and unless a contrast is used, you cannot see the lymph nodes, which I already told you, and in a contrast you can see the lung better, even the lymph nodes better. So always advise a contrast enhanced CT scan. And we also do a HRCT, another terminology, high resolution CT scan, that is called HRCT. So these are the common diagnostic tests we use.
And sir, another question is there from my side, that is CA-125 for the blood test and all. So is it also, I mean, applicable for diagnosing the CA lung and all? Is it possible?
No. CA-125 is essentially for ovarian cancers. We also do for other cancers like uterine cancer, which is close to ovary. But for lung cancer, we don't have any specific tumor marker.
Okay. Okay, sir. Thank you, sir. So any other, if having question, please do it fast, because sir is having some another meeting. So he could not wait for a long. So
Dr. Priyanka, please share my email and mobile number to your friends and colleagues in case anybody has questions. Sorry, I thought I'll put it up one, but in a hurry I missed it. I thought I had it in the last slide, but I missed it. But we will be joining some more meetings later on.
Sure, sir. Sure, sir. Thank you so much, sir, for coming today also. Thank you.
Yeah. All the best. Wish you all the best, and hope we have a better time early next year and we meet up in a different situation. We can interact more. Thank you, everybody, for your.
Thank you so much, sir. And now having one. Yes, sir. Okay, sir.
Yeah, thank you.
So now having one announcement that tomorrow we are knowing that our program is going to be finished, our total webinar 2020. So tomorrow at the 6 p.m. The presentation is there by me only. The topic is medical legal aspect and forensic awareness for Ayurvedic surgeon. Okay, and afterwards 7 p.m. onwards there is having the thanks of vote. This ceremony will be conducted by our principal sir, Tapas Kumar Mandal sir, and along with all the others, all management and all. So I'm requesting that everybody should come tomorrow, especially for this validation program. And I think tomorrow at 6 p.m. we'll be again. We'll meet here as like today also. Okay, thank you so much. Now time came to say good night.